We're back. Thanks, Nick. Really appreciate you stopping by and joining the show here. So we have Nick Barcellona from Temple, and you're the CFO.
Yes.
And you have purview for a couple billion in net patient revenue and growing.
Yes.
And I imagine that you're not unlike a lot of CFOs doing some of your own innovation in revenue cycle. It could be other areas. Just to kick things off, so what are you excited about these days in this topic?
Yeah, so Temple Health is growing and an exciting place to be, $2.6 billion in revenue.
Yep.
We're predominantly a government payer organization, right? So we're about almost 86% government pay.
Yep.
About half Medicaid, half that's Medicaid, about the other half Medicare.
Yep.
55% of our Medicare lives are duals. So
Okay.
we're the largest Medicaid provider in our area, one of the largest in the country.
Okay.
So I think we face the same challenges as everyone else, right? But we think about innovation and investing in technology and changing processes. It's often a question of, can you afford to do it, right?
Yeah.
You hear this all over the place, especially in the current environment, right? You look at what's going on with the workforce, and we're facing it too. We're having significant challenges. I think we're navigating as well, or maybe even better than some of the other folks out there.
Great.
And what's fascinating to me is I keep reading about folks pulling back on innovation, pulling back on investing in new technology, and it just boggles my mind, right?
Yeah.
When you think about it, I get it, right? You have to hit your numbers, you have to make your margin.
Sure.
But what better way to ensure long-term success than investing in process automation, in technology, in AI? So we try to really be really thoughtful about our investments.
Yep.
You have to balance the infrastructure decisions, making sure you're making payroll week to week. That's a real thing.
Absolutely, sure.
But you have to find ways to invest, or you're going to get in this sort of vicious circle where you spiral down.
Yeah.
And we're very focused on spiraling up. Right?
Yep.
It's something our CEO talks a lot about. It's something I talk a lot about. And we focus on the patients, the care, and then making smart investments so we can keep that spiral going up.
Yeah, it's long-term thinking. That's what you touched on. You can't be situational, or what I call you can't be a day trader when it comes to the topic of innovation. Because what about next year and the year after that? But it is an art to figure out what the balance is. And do you use a qualification process, or like how? Everybody comes to the CFO wants money, right?
Yes.
And largely, you have to invest in patient care.
Yes.
And sure, we got to go after revenue cycle improvement and other things. So what's your process?
Yeah, so, it's not that complicated. One of the things I like to say is keep it simple.
Yeah.
We focus on that. I don't think you want to make it too complicated. We really try to balance about 50-50 between, investment in day-to-day activities, so sort of keeping the lights on, making payroll, and the future.
Yep.
And so that's not a hard, fast rule,
Sure.
but it's sort of a, kind of a thumb in the air.
Absolutely, sure.
And so for us, we're having every single project put together an ROI.
Yep.
We review those ROIs with our leadership group and ultimately the C-suite, right?
Yep.
So CEO, CIO, me.
Yep.
And then one of the things that I think a lot of organizations don't do is look back analysis, right? So you do this ROI and the vendor comes in and tells you it's going to be magic and everything's going to be better.
Yep.
And then 6 months later you spent this money and then no one's tracking it to see did you actually deliver on it. So that's something that we focus on a lot, is making sure that we're investing in something, we want it to be successful, but if it's not working, we're either going to get rid of it or we're going to go back and say, you said it would do this, it's not, tell us how we get there. So, I think if you make it too formal, you end up spending more resources and time on the process.
Yeah.
So it's a little bit of a, you have to find that fine line and walk it.
Yeah. That's funny you say that. Even in our own implementations with clients, the first dashboard we talk with clients about is setting up the dashboard on us. Make sure that we're paying for ourselves, right?
Yeah.
So, we're an analytics company, but in QAT, like, what are you going to do for us, right? It's important, So great. So in terms of innovation spend, where are you directing dollars these days? What are some of the themes or topical areas?
Sure. So we're focused on, right now we just came out of an Epic Go Live. So October 1st we went house-wide live with Epic Rev Cycle. So we did clinicals first, then we did the back of the house.
Great, congrats.
Yeah, thanks.
Yeah.
knock on wood.
I'm sure a few battle scars along the way.
Yes, certainly challenging, but I think the team, I have to hand it to our operational and clinical leaders, right? The finance team, the IT team, they did a lot of work, but it was successful because we had partnership and engagement from our front of the house, right?
Yeah.
The clinical folks, the operational folks, they dug in there in the trenches with us when things weren't working, when queues were building up, they were right there with us. And I think
great.
that partnership to me is key for any kind of investment,
Sure.
right? So for us, we've really put a pause on a lot of significant investment, in innovation, and I think I'm very excited and hungry to get back into that space. One of the first things that we're doing is we're moving into modified activity-based accounting, cost accounting system that we're putting in. So it's something that I have some history with. I started my career as an engineer, came from the for-profit sector, sort of grew up in manufacturing, cost accounting, and I've always been boggled by how sort of basic the cost accounting is in healthcare. It sort of frustrates me, right? So
I share that, by the way.
Yeah, one of the, how can you walk in and get a procedure as a consumer and not actually have a concept of how much it's going to cost? Right. I get it that,
the allocation methods are, let's say, crude in many cases.
100%.
And shouldn't be.
Yeah, it's like you spread it like peanut butter, right?
Yeah, exactly.
How can you make
more like a scalpel.
Yeah. How can you make informed or strategic decisions about investments, where you need to grow, where you need to implement or leverage technology to be successful? And so that's one thing that I'm very excited about. So actually January of 23, we're going to go live with our new cost accounting system.
Oh, great.
So moving from the old school ratio of cost to charges, like you were talking about,
exactly.
and move into a modified activity-based costing.
And I imagine you're being smart about it. You kind of do ABC on the 2080, right? So 20% of the surgeries, 20% of inpatient. You just start with 2080 and do some activity-based costing on that. Yeah, you can't activity-based cost every single line item in the CDM or SIM, but if you have good ABC in the top tier.
That's exactly right. Right? It's the classic Pareto, right?
Yeah,
There's plenty of things that you should just spread like peanut butter, right? That you're not. It's a step function from a cost accounting perspective, right? So you're not going to change a decision, based on one or two more patients or one or two less patients for lots of indirect costs. But you have to be able to say, all of my direct costs, I'm going to allocate them to a patient encounter level, and not just in a specific one-time patient engagement, right? Across the continuum, or sort of slicing horizontally, so that you can see everything, right? So if you come in for a transplant, it's not just when you're on the table getting your transplant, right? It's your pre-work, it's your post-work, it's all of the, outside of the four walls. You want to be able to understand that so that you can truly understand what's a profitable service line and what's not.
I always say, like, in some of the work we do in this area, it's like you have a good cost accountant, but you should have a process efficiency expert. And they're looking at it through a different lens, because when you're trapping all those costs, step one, you may have to trap the cost, but you're also seeing, there's a node there that could be improved. We can take cost out for the next run, right?
That's right. That's exactly right.
Yeah. Awesome.
And I think, I'm very excited to see the engagement from the clinical team. Right. So for me, as a CFO, who sometimes I'll talk to my peers out there, and they say, well, you can get to the same answer if you do it the old way. I say, well, sure, but you're talking about data that's 9 months, 10 months, 12 months, 18 months old, right? So a surgeon, in the OR isn't making a decision or changing a decision based on that data, right?
That's right.
They might retroactively be able to go back and say, well, okay, we should use this suture instead of that suture. So it's maybe good for supply chain decisions, but you're not going to change something as it relates to how you're actually providing care. In the moment where you're going to say, all right, this patient came in for complex appendicitis, and if they ambulate, within 4 hours or T+4, you're going to have better outcomes, number one, most important, right? But you're also going to drive down your costs because they're going to have a lower length of stay, they're going to maybe use less drugs. So that's what really gets me going, is to get the data to the point where you can actually give it to the frontline caregivers, and it might actually impact or change a decision about
and they
the
see
care
what,
pattern.
I think it's really, really true over the years that people that have done great work in this area, the notion that the optimized cost is also the optimized quality.
Right. Absolutely.
It's like the simplicity of laparoscopic. Less invasive, shorter length of stay, better outcome. That's what you're really chasing. When you can crush cost efficiency and outcomes, it takes a village.
Yes. Yes.
You need that 360-degree multidisciplinary team, right? I say that because those words always crack me up. Like it's like holistic, multidisciplinary. It's like, but it is true. You need all of those opinions really thinking about it through their lens. How can they move the needle?
Yeah, well, and in my experience, clinicians are very data driven, right? So just like the finance team, they're very data driven, right?
Especially if you show them the data.
Yeah.
Sometimes they don't. You got to show me.
They like statistics, I think, even more than we do in the finance realm. And so you be transparent with the data. You have open conversations. And in my experience, it is the inverse, right, of what people typically expect. If you focus on the quality and deliver high quality, you're actually going to have better cost and better financial performance in the long run. So that's one of the things that we really are trying to do with our data.
That's great. And what's the data refresh rate on that? Because a lot of people, to your point, monthly's too not good, right?
Yeah.
We've helped people do like intraday or weekly. Just kind of the idea of current time. Whatever the data set you can give us current, we'll line it up in some data lineage, right?
Yeah, so it's going to depend on the data element, but those that are being spread at a direct level, it's a daily feed.
Good.
And
great,
to your point, it's working towards. Could you even get it, to an hourly feed?
Yeah.
And I think there are actually some cost drivers or activity drivers where you can.
Yeah.
We're going to, I think, crawl a little bit before we sprint, but that's exactly the way we should be thinking about it.
Another thing that comes up in this regard is people say, well, maybe daily's overkill, but very often you say, well, daily's actually easier to implement from an infrastructure.
That's right.
So you don't have to look at it daily, but let the feeds run daily or even real time. Sometimes these days, smart fire and things like that as they get more mature, if you can implement smart fire and it's real time, we'll let it go, right? That's efficiency and stability of data, and your decision-making process can be what it is, right?
Yeah, and being an academic medical center, and we're very focused on the pillar of academic and proud to be a teaching and training institution.
Sure,
and I think there's a lot of application to not just use this data and frankly use innovation and technology in just the clinical delivery side, but I think to also use it in the research, in the teaching side of what we do.
That's in your DNA, to your point.
Yeah, it's a big gap though. It's something that a lot of folks aren't talking about, and we're really trying to change that in our organization.
Do you use a methodology like Lean Six Sigma or anything? What's your quality?
We do. Yes, we do. We have a PMO or project management office. It's a team of good, solid engineers after my heart. And yes, we do use Six Sigma.
Yep, great.
Yeah.
And because it's sometimes hard to find the right balance of, it's still about getting things done.
Yeah.
So let's go chase defects in the Pareto principle, but let's get things done and not get too,
Yeah, being I guess I'll call it reformed engineer, I think when you do consulting engagements, sometimes you'll have folks come in and they're so focused on the terminology and the process,
the buzzwords
and the buzzwords,
corporate BS,
right? And it's really about driving the improvement, tracking the outcomes, and some of the core tools that you're going to use. Some of the statistical process control charts, right? The run charts, the way of thinking about things, the 5 whys. Some of the sort of the core elements of process improvement. And really, they jive quite well with physicians and the training of physicians and nurses and clinicians. And so I think it's if you can get past some of this sort of technical terminology, you'll find that folks actually really, first off, they already understand it because they've been doing it for years. They just use different terms, right? And they like it, right? They get excited.
I sense that you guys are, able to get things done, right? So what kind of role? I'm big on change management. We've learned the hard way that you can have great ideas, great technology, great products, but adoption and utilization is always a function of change management. And can you get people excited about change in a way that they can relate to what's in it for them, right? And ultimately, hopefully it's all about the patient. But it's one of those nuanced things. Do you guys use change management in your in your
We
everyday?
we do, and you know, I'll come back to this spiraling up that I started with, right? And,
Yeah.
you know, I think it's really a core tenet that we talk about a lot. We talk about it to the investors, we talk about it to our board, we talk about it to
Yeah.
our staff.
Yeah. I'm going to start using that, by the way. I
Yeah.
like that spiral up.
Well,
Yeah.
and it starts with the patient, and it starts with the outcomes for the patients, and then, you know, the community and our team and engagement with our employees, and, you know, just focusing on the results. And really what I think you'll find is folks get excited about it, right?
Yeah.
And they see the results. They see that, hey, you know, we've been challenged for many years with our payer mix. You know, sort of, we were stagnant for a while. We weren't growing. We've gone through some significant changes in our leadership. We've focused on shifting the culture at the top. We're very flat now, very flat organization, lots of open doors. You know, no boundaries, as we like to say.
Yeah.
And I think for the chairs, for the nursing unit directors, the leaders, for me, it's kind of exciting because they can see results, right?
Yeah.
So, hey, we're going to do
Yeah.
X. This is going to improve our process. It's going to improve the patient outcomes. Oh, by the way, we're going to get paid more.
Yeah.
And then
Yeah.
we're going to invest in you. We're going to invest in the staff. We're going to
Yeah.
invest in the team. We're going to invest in the infrastructure. We're going to invest in growth and innovation. And then you start to see those things coming in, and it's like, okay, now I want to do more of it. And so,
Yeah.
you know, then you can start to speed it. It's that
Success
flywheel
breeds
concept,
success.
right?
Yeah, you get
Yeah.
something that people feel like they see the impact. Okay, now let's go do the next thing.
Yeah, you know, Mike Young, our CEO, and our other leaders, you know, we get asked this question a lot. Well, you know, what's the secret sauce, right? Everybody asks that. And
Yeah.
there is no secret sauce.
Yeah.
It's doing all of the little things, doing them well, holding people accountable, and then communicating the results, you know, and then focusing on that same vision that you have with your
Yeah.
team, right? That's
Yeah.
how you change a culture.
And yet everything that you just said is the secret sauce, right?
Yes.
I guess it's like the secret sauce is a recipe of hard work, focused priorities, right? Skip the BS, right?
Yeah.
Even that in and of itself is a methodology that I would say that not everybody runs.
That's
You
right.
know, what about when the idea of failing fast? Like, do you guys let your innovations one of these topics that if you study it, right, the biggest transformers are the ones unafraid to fail,
Yeah.
break some stuff, right? There's a
Yeah.
certain allocation.
So we're pretty lucky to have our CEO, Mike Young. Mike's been a hospital CEO for more than 30 years.
Okay.
He's done a number of turnarounds really throughout the country. You know, and I think it's okay to say he's sort of at the tail end of his career. This is
Yep.
his last job, and he's happy about that.
Yep.
He's proud of that. And so
Sure.
we're pretty lucky because, you know, Mike's mantra is, you know, if we get it wrong, it's my fault. If we get it right, it's because of you.
Yeah. Sure.
And if you come to him with a good idea, his response is always, "Why didn't we do this yesterday?"
Yeah.
Not, you know, here's the 3 committees that we need to put in place to
Yes.
review the white paper about why someone thinks this might be a good idea.
Yeah.
So to your point, no BS. It's
Yeah.
very, you know, he's accountable, he holds us accountable, but, you know, if we have a good idea, we're going to go, and we're going to go fast. And if it doesn't work, we're going to change it.
Yeah. Yeah. That's great. Where would you like to be, like, if you just go out, you know, 3 to 5 years, you know, what's the headline that says, man, I'm glad we did that?
Yeah, I mean, I think from my perspective, and I'll stick to you know, more of a finance realm for
Sure.
this. I mean, I think we're one of the few organizations that has fully complied with price transparency. We're proud of that.
Not easy thing to do.
Not easy. We're
Yeah.
proud of that.
Yeah.
You know, I think being in front of that with our patients, having our patients, meeting them where they are, right? You heard that from one of the presentations earlier today. I think that was a good way to describe it. So for us, I think we want to take innovation, you know, take technology and use it to actually deliver better care for our patients and deliver a better experience for our
Yeah.
patients, right? That to me, so when you think about things like, you know, having real-time quotes for your patients, think about cost accounting so you can actually tell whether, you know, someone's going to have a $1,000 bill or a $10,000 bill,
Yeah.
and be able to communicate that effectively. You know, leverage technology, things like Epic and MyChart, and have folks be able to, access their medical information and schedule an appointment, change an appointment, get reminders. These are things that we're all sort of doing in pockets and very fragmented. For me, I want to see that really advance in the next 3 to 5 years, and I want to see us leverage technology to actually drive cost deflation. Coming from the for-profit, long-cycle industrial world at the start of my career, I'm used to it now, sadly, because I've been in healthcare for 20 years, but it always puzzled me that this was like the only industry where I feel like technology and innovation would drive our cost structure up, not down. We've got to change that.
We got to change that.
Got to change that.
Very, very
long
well
answer, sorry. But
No, I was hanging on to every word. You couldn't be more nailing it on that. It's, I guess it's connected to the spiral up too. It's
Absolutely.
a different way to think about it, but it's we got to stop saying that healthcare is a decade behind. I'm tired of that. I've been in healthcare for 30 years. They've been saying that's been said my entire 30-year career. I'm sick of that line. So let's get past that. Right.
It's the power of change, and I think it's changing your culture and having a culture that's bought in on change and thinking nimbly, right? So not being afraid to try something different. And I'll say, I do think, there's silver linings, right? And a silver lining of the pandemic is I think it forced a lot of organizations, and I would say ours included, to break down some of those historical barriers.
Good point.
Where things were pretty difficult to change. It had a lot more process, and it was a very unfortunate thing, but one of the good things that came from the pandemic is that it forced us to be more comfortable with rapid paced change and to innovate on the fly, to sort of build the airplane while you're flying it, because we had to. And there were bad things about that, but there were some good things about it too, right?
No, it is this simple. I sat in a CEO panel and after a year of COVID, and the question was asked, like, why were we talking about this being a 3 to 4 year journey to do telemedicine, and we did it
example.
And we did it in a month. And so they were sitting back and reflecting on that, like, well, why did we do that? And it's like, well, because that's what we do. So part of it is just like, now the important thing is, let's not forget that.
Right.
Let's not forget that we can get things done, we can move fast.
That's my biggest fear, is we regress back to where we were. And I think some of the macroeconomic pressure that we're facing right now is not going to let us do that, because we have to keep changing and innovating, or we're not going to be able to make payroll. We're not going to be able to invest in innovation and invest in our employees and our workforce like we need to.
I mean, let me ask you this. You're a younger CFO relative to some of your peers, right? And I think that's a great thing. I've been really encouraged by seeing in many positions like younger leadership, because you grew up with more technology. I grew up with more technology. Like, it's not as tough of a sell for younger leaders to like drive change using proper tech. And also wanting to create like a more consumer retail experience. Which we have all these great retail experiences, but in healthcare, why does it still? It's not as good, let's say.
So couple comments. I love this topic, right? So prior to taking the CFO role, I worked in operations at Children's in Pittsburgh for UPMC. So I was on the ops side prior to moving back into finance. And it would always fascinate me. I'd have these conversations with wonderful physician leaders, and I have them at Temple. I had them where I came from. Where I think they would say, well, our patients aren't willing or ready to accept technology. There's no data to support that. In fact, I've seen that the patients are hungry for it, and probably more importantly, the definition of quality, right, is something that is always a touchy subject. Yes, obviously the outcomes, patient safety matters, and it's critical, but the patient experience is an indicator of quality. Whether you want to admit it or not, how fast you got in, how nice they were at the front desk. Did they look you in the eye? Did they shake your hand if if we're allowed to shake hands again, right? Or did they say please and thank you? Did they ask how you're feeling? Those things go a long way, and they're a part of changing our culture and driving quality and innovation, right? So
Yeah.
it's not just the high tech,
Yeah.
it's also the high touch.
Yeah, oh,
And
absolutely.
we've got to put the two together.
Yeah, you got to put the two together. Absolutely. Well, yeah, because it just, you can order a table for 12, book a rental car, and order a flight on your coffee break.
Yeah.
In a very elegant digital experience, and then you go to reorder your prescription, and it's not like that.
Right.
It's still not like that. So
That's right.
we got to keep pushing it. So it's as natural as those experiences.
Well, and
why shouldn't it be?
And I do think, and we're doing this, so kudos to our leadership team at Temple, and we were doing this UPMC, so kudos to the team there. But I think there's this fallacy in thinking that the Medicare population is averse to technology. That's not true.
Oh, it's not true.
It's not true at all.
Yeah, just because look, we all have family members. You see your aunts, uncles, grandparents. They have iPads and they're like navigating it like ninjas these days.
That's right.
It's like,
that's right.
So
yeah, and they want that same experience. Everyone, you can't build a one size fits all, but they want access to technology. They want access to their information. They want people to be nice to them. It's not rocket science, right?
Well, and if you build things properly from a not just UI UX but client experience, then it will be simple.
Yeah.
Right. That's the key. Well, hey Nick, I just want to thank you again for coming, hanging out with us, and driving this topic forward. And best of luck to you as you guys keep kicking butt. We'll be watching Temple, and love to have you back.
Thanks for having me.
Yeah, likewise.
Thank you.
All right.